we really have some very exciting new innovations that are here and that are on their way in the area of joint replacement. We're going to focus primarily on hip and knee replacement, and we're going to start talking about knee replacement first. That's probably the area where we're seeing the largest development and the largest changes that are going on. Some of the things that we are currently doing, this is a system called the Visionnaire. These props that I have, the implants, I have to do a disclosure, are provided by a company, Smith & Nephew, which makes some of the implants that we use here. One of the things that you hear about with knee replacements is am I going to get a woman's knee or I'm going to get a man's knee? Has anybody heard that? Anybody heard that? Yeah, that's actually a pretty big, it's really mainly advertising. During the surgical procedure, we size the implant based on that specific patient. One of the things that has really made this accurate is a system which is called Visionnaire, and I've got some information on the Visionnaire system. What we do with the Visionnaire system is we do an MRI scan of the knee before the surgery. So we do the MRI scan and we do a three-dimensional reconstruction of the patient's knee. Okay? We also do a long X-ray which helps us determine the alignment of that patient's knee. So we accurately can get their alignment and we know the exact size and shape of their knee. So from the MRI we get an image that looks just like this. Okay, so this is the upper bone, this is the femur bone here, and this is the tibia bone here. Well, what do we do with that three-dimensional reconstruction? From that reconstruction, we manufacture patient-specific blocks. Okay, so for this patient's MRI, this is made for that patient. So during the surgical procedure, we open the knee up in the standard way, but this block is made just to fit exactly over that particular patient. Okay? We put this block in place and then we're able to prepare the knee for the patient's new implant. Why is this important? Well, this tells us the size that patient requires. It tells us the rotation of where that implant will be best for that patient. It tells us the flexion and extension that's best for that patient, and also the alignment in this direction. So it's another way that we can decrease the errors of the procedure, and we can make that procedure much more specific for that particular patient. So we've done that on the upper bone, the femur, and then we can do the same thing on the lower bone, which is the tibia. Okay? So this fits specifically on that patient's bone. We pin it in place, then we make the cut through here in the exact dimensions that we need to based on the MRI scan. This is a big advantage for the patients. It's also a big advantage for us. Normally during the surgery we have volumes and volumes of instruments that we need to use. Well, we don't need to use those anymore. So why is that good? Well, it's easier for the hospital staff because they don't have to get all this stuff prepared. And also it's less things that are sitting out that are exposed to the environment. When things are exposed to the environment, you have a higher risk of contamination, infection, that type of thing. Okay, so that's why that's important. The other thing that we do differently is a lot of places do the same knee replacement for every single patient. Okay, if you're 40 years old or you're 90 years old, you're going to get the same implant made out of the same materials. We try to do patient-specific implanting. So if you're a patient that's very active, you're a patient that wants to get back to higher demand activities, then we're going to use a different material for that patient. One of those materials is a material which is called oxinium. Oxinium is a black material, it's a metal, and that metal acts like ceramic. And we found that if we put this in a machine that moves it back and forth day and night for the equivalent of 30 years, the wearing in this knee is very, very low. Approximately 95% less than a standard knee replacement. Okay? So if you're an active person that likes to get out and do more and more things, that's important for that person. The other thing that we do is a lot of patients, not the entire knee is worn out. Only a portion of the knee is worn out. Well, why replace the entire knee if only a portion of the knee is worn out? You can do a 1/3 replacement, you can do a 2/3 replacement, and this is an example of a 2/3 replacement. It has replaced the inner side of the knee, it's replaced the area in the knee where the kneecap rubs, here, but this outer side of the knee is left alone. So the more normal structures that we can leave behind, the more normal that patient's knee is going to feel. Okay? We also have an implant where we can just replace this portion of the knee. And this is the portion of the knee where the kneecap rubs. So we can do 1/3, we can do 2/3, or we can do the entire knee for a replacement. To show you exactly what is done during a knee replacement, a lot of people think that a knee replacement, you're taking out the entire knee and you're putting in an entire new knee. That's actually not correct. What we're really doing is resurfacing the knee. So it's more like a retread on a tire. So when the tire's worn out, you put a new tread on it. Same thing in your knee. When it's worn out, we put on a new tread. So this is a knee joint here. So during the surgical procedure, we remove about 1/4 inch of the lower bone, like this. We also remove about 1/4 inch of the upper bone. Okay, so essentially we're just squaring off that bone. So where the cartilage is worn, that part of the bone and that remaining cartilage is removed. Well, what do we do with that then? Well, then we're going to put our new surface on it. And this is an example of that oxynia material. And so we put the new surface on. And I have done this before. So, usually it's... Okay. So we've got the surface on the upper bone. And we put the new surface on the lower bone. Like this. So then as the patient now moves, the joint moves like this. So now it's the metal surface rubbing on the plastic surface. Okay? So that's an important concept to understand. And this is an actual implant in place. This particular patient must have had a lot of arthritis under the kneecap, so we put a new surface on the kneecap. Okay? This represents the bone, and then you can see the implants here and here. And so then as the patient moves, that's how the knee moves. Okay? So that's what relieves the pain, by getting rid of the rough arthritic surface and replacing it with this smooth metal and plastic surface. So I've got some information on all these different implants. Well, what else is new? Well, you may have heard advertisements about robotic surgery in other places. There's robotic surgery for prostate cancer. One of them is called the Da Vinci system. The Da Vinci system is a navigation system that requires less exposure for that patient to do the surgery. And that's one of our main goals, is to do less to the patient but still accomplish the same goal. And the key is that you want to make sure you can still accomplish the same goal, because the joint replacements have been very, very successful. Patients do very, very well with them. They last a long time. So we want to make sure that if we're making it easier, we still want to get those very, very good results. Okay. If you want any information on any of those procedures, I have those up here. One of the things that we're working on from a robotic standpoint is a way of preparing that joint for the implants without squaring off the end of the bone, but actually using a robot to help us plan and tell us exactly where we need to remove bone. Part of that robotic system is using this computer, okay? This computer system, which is called computer navigation, is going to be mated with a specific cutting system that the robot, which is the robot which actually tells you where and how much of the bone you need to remove for the procedure. Are we to the point where we can register, Chad?
Yes.
Okay. So this is a navigation system that we currently do use. Okay, this is called computer navigation. And so why would we want to use this? Well, the computer is another way of making sure that we put the implants in the correct position, that we have the correct size of the implants, and we have the correct alignment of the extremity. If you put a joint replacement in malposition, so if you come out of your surgery and you're like this, that's never good, okay? So we want to make sure that the alignment is correct. Well, the reason that's important, one is it doesn't look good, and the other is the implants don't last as long. So if we don't have a good alignment, it's going to tend to wear out quicker. If any of my patients in here have a crooked leg, please leave, okay? Someone may see it. Okay. All right, so this is the system. I'll just kind of show you how it works. This uses an infrared system, and what it does is it sends a signal to these little reflector balls here, these little shiny balls. And so the computer,
sorry, let's see. Can you see it okay?
the computer is picking up the position of where this leg is, okay? So this is actually one of the processes we go through for the surgery. So the computer helps us plan where to put the implants and the alignment of the implants. We don't use that on every single patient. Patients that have a big deformity or somebody that has a very, very large leg, that helps us a lot, okay? But for the standard patient, we don't always use the computer system. Once we're able to marry that with a robotic system, then it will become extremely important for patients. I think the robotic system is going to be kind of the wave of the future. The thing that I don't like about it is when we've used the robot over in our cadaver lab is I feel like I don't have to be there because the computer and the robot are doing most of the work. The biggest input that I have is actually planning the surgery, okay? So look for that, I would say in the future, probably within the next 4 to 6 months we will have one of the types of robotic systems here. We're actually partnering with a company to help with the development of their robotic system, okay? So that's kind of the latest thing about knee replacement. Does anybody have any questions about that particular area? Yeah.
Is that going to make it a lot more expensive?
When you use a system like this, it doesn't change the cost to the patient. It changes really the cost to the hospital. The more expensive implant I put in, it costs the hospital. It doesn't cost the patients. The patients get charged essentially the same amount every time, okay? There are a few private insurance companies that do pay for the implants separate from the patient's hospital stay, but generally it's all kind of wrapped into one big package. Probably the biggest question I get from people is, you know, do you have something you can just inject in my knee to put that cartilage back and I'm ready to go again? The problem with arthritis is it's not just the cartilage is gone, it's that the joint has changed, okay? So a lot of people, you have deformity, so the joint's like this. I always say that you can't pen a hog in a ditch because they go right through your legs because you're so bow-legged, okay? So you can be bow-legged, you can be knock-kneed. So the joint is different, the ligaments are different, so you really can't just inject cartilage to replace it. Now, if you have a piece of cartilage that's torn off, and you see that in athletes a lot, where the cartilage is damaged, well, the rest of the knee is normal. They just have a place where their cartilage is damaged. Well, we can replace that cartilage with cartilage. You can grow cartilage and put that cartilage back in the knee, but that's different than somebody that has arthritis. So right now, we're relying on artificial surfaces to take care of the problem. What I envision is going to happen in the future is that we will be able to grow, say, the end of your femur bone. So we'll be able to grow this much of your bone. And we can essentially take that bone that is truly yours, whether it's through a cloning process or using some of your cells to form a new end of the bone for you, and taking your own material and putting it back in, okay? That is probably the ideal scenario for joint replacement. And will we ever get to that? Yeah, we will. When is that? I have absolutely no idea. So one of the exciting things is that we have a new research lab, which part of it is going to be cartilage research, which is on our 4th floor of our office building. We right now have a cadaver lab where we can work on new technologies, we can work on new equipment, we can try it out, and we can practice it before we practice on you. So it's really a great environment for us to be in the development phase and to kind of be on the cutting edge of what is available and what we can do for patients.